Across the board, the general population, care homes and hospitals. Not one overall picture. Instead, we have now learned 3 separate epidemics. As the Easter weekend comes to an end, there are signs that people have been following the social distancing rules and that infection rates may be flattening off. The science appears to show that one person is capable of transmitting COVID-19 to 3 others, except when you have measures like social distancing. So in the UK, they believe that has fallen from 1 person to less than 1 other, except in care homes and hospitals. Now those same experts say that there is a data blind spot. They don't know what that transmission rate is. As more care homes report multiple deaths and increasing numbers of patients are being infected while in hospital, the scientists are looking at how they can measure this, if not geographically, at least nationally. At today's Downing Street press conference, the Chief Medical Officer, Professor Chris Whitty, confirmed the sheer scale of it.
In the last 24 hours, there have been 92 care homes where an outbreak has been detected.
The experts trying to model the care home and hospital transmission rates will report to the Scientific Advisory Group for Emergencies, or SAGE, who in turn advise ministers.
And what we've got to do, though, is try and look at how we prioritise things like care services, where every single person who's in a care service is in a high-risk category. And we need testing so that we know exactly who's COVID-19 positive and we can respond appropriately.
This is not just about personal protective equipment or PPE, but inevitably it will form part of the discussion over cross-infection. This doctor, Ariel Eno, showed us pictures of the masks she's used in her hospital's A&E over the past weeks, from the flimsy to the full shield.
Over the last week, more often than not, we have had FFP3 masks when I've started my shift, but often towards the end of the day. So when the night staff come on, we're normally running low or out of them completely. I guess an important thing to say is that in my department, as with many other departments, there's not a clear division between beds. So there might be curtains drawn across or even the curtains open. So there might be someone receiving high flow oxygen in one of the cubicles, but then the cubicle opposite and the corridor outside that cubicle, there'll be people walking just either with surgical face masks or sometimes no face mask at all.
More PPE did go to hospitals over the weekend, including much needed gowns, but care homes are still reporting supply shortages.
I think what we now want to hear from government is absolute assurances about the supplies going forward, not just that they've got the stocks at national level, but that they've got a system in place which makes sure that whether you're a care home, whether you're a GP practice or a community nurse or a big hospital, you are going to get the supplies of personal protective equipment that you and your staff need.
And there is the same message for testing. In the past few hours, it's been confirmed that 13 residents from the Stanley Park care home in County Durham have died of coronavirus. The staff are all said to have had PPE, but it adds to the evidence that the infection can spread further and faster in these homes than in the general population.
Victoria McDonald. Now, staff looking after the sick and elderly in care homes have been praised by the Chief Medical Officer, Professor Chris Whitty. He said they were doing a very difficult job for their residents. A care home in Nottinghamshire is reeling from the news that 9 of its residents have died over the past few days. Staff describing the situation as leaving them broken inside. Jane Dodge has this report.
Tucked away between the rolling hills of North Nottinghamshire, Wren Hall has been looking after elderly people with dementia for more than 30 years. But the rural idyll was brutally shattered just over 2 weeks ago. That's when the first resident, an 86-year-old man, died from COVID-19. Since then, another 8 residents have passed away. The most recent, a 91-year-old man who died this morning. 16 others here are now showing symptoms of the disease, but that didn't stop staff turning up for work this afternoon. Did you have any second thoughts about coming into work today?
No, not at all, no.
Why not? Are you not worried about catching COVID-19?
I've got a job to do, I'll come and do it. Whenever I'm well enough to, I'll keep coming. If I get COVID-19, then so be it. If I don't, then I'm lucky.
Emma Copley is struggling with how her job has now changed.
You just think, hang on, that person's end of life and we're all in there with masks on. They can't see our face. We can't show them that we're there. We're touching them like with gloves and stuff. And it's not the way Wrenhall deals with end of life, but it's how we have to do it.
We can care for anybody from 48 years upwards.
The video on the care home's website is of happier times. Wrenhall was judged outstanding just 4 months ago by the Care Quality Commission. Staff have filmed inside the care home now. Common rooms are empty, residents are confined to their bedrooms.
In our isolation area, we have relevant PPE.
It's an ongoing battle to find the necessary personal protective equipment for staff.
So we're using a plastic apron, which, as you can see, does not cover the whole person's body.
It's taken the manager of the care home many hours trying to find adequate PPE. With the loss of so many of the residents she calls family members, Anita Astle is exhausted. How are you?
Broken, I think. Yep. Usually this job is the best job in the world. It's so rewarding. We're having to monitor people very closely. We are observing people deteriorate very rapidly. And the awful thing is there's very little that we're being able to do to stop that.
Do you think any of the residents that you've sadly lost here might have survived if they'd gone to hospital?
No. I think the reality is if they'd gone to hospital, they'd probably have been sent back.
Is there anything that you have lacked that would have made your job easier in these desperate times?
It's a boring story now, isn't it? But we've been chasing PPE. It's not so much the aprons and the gloves. It's the masks. And we're now spending hours trying to source them.
How hard then has it been for you to see people lose their lives in this current pandemic?
It's the most soul-destroying thing that I've ever experienced.
One thing that will help staff here is access to tests for the virus. The Health Secretary, Matt Hancock, promised they'd be made available for NHS and social care staff. That can't come soon enough for everyone at Wrenhall.
Now, can we truly rely on the figures for the number of deaths from COVID-19? This programme has been told that in some cases, coronavirus is not being put down as a cause of suspected death, a suspected cause of death, meaning the true number of deaths may not actually be getting properly recorded. Our Scotland correspondent, Jenkins, joins us now. Kieran, why is this happening?
John, this is about the official count of coronavirus deaths, particularly in England. You'll be familiar with the daily count of deaths in hospital that's announced by the UK government, and a new weekly count from the Office for National Statistics that includes care home and community deaths. Well, we've been speaking to a whistleblower who says they fear there are some deaths, coronavirus or suspected coronavirus, they believe are not being counted at all. Now, GPs, of course, have to complete medical death certificates, and our whistleblower describes a system they allege is overwhelmed, and they believe dozens and dozens of errors are being made that may raise questions about the accuracy of the official death toll.
381 people died.
1,408 have, very sadly, died.
7,097 have now died.
Each day, the UK government announces the number of new coronavirus hospital deaths.
10,000 deaths related to coronavirus.
A staggering figure. But the real number of deaths is even higher. Last week, the Office for National Statistics began a new weekly update of all deaths where coronavirus is mentioned on a death certificate. The figures include deaths in care homes and the community, but they lag weeks behind the daily update on hospital deaths. So we don't yet have a true picture. And this programme has heard from a whistleblower who alleges we never will. We've spoken to a whistleblower who is deeply involved with the registration of deaths in an area in the south of England. They fear where they are, the number of coronavirus deaths in care homes is not being reflected in any of the official statistics. Where people die in a care home or in the community, the whistleblower alleges coronavirus is sometimes left off their death certificates entirely. And if those deaths were being counted, the whistleblower fears the number of deaths in care homes in their region last week would have been equal to the number of deaths in hospital. The whistleblower told us they felt GPs were under too much pressure and were sometimes not recording the actual cause of death on death certificates and resorting to guesswork. The whistleblower told us they feared old age dementia or Alzheimer's were being used as the easy option by GPs for a cause of death, with no mention of COVID-19 or even suspected COVID-19. A huge burden on GPs means they may not have seen a patient in the weeks leading up to their death, or the patient may have been seen by someone else. Our whistleblower says there have been dozens and dozens of errors by well-meaning GPs on death certificates. And then our whistleblower told us this, of a telephone conversation with a GP in which they logged a death as Alzheimer's, even though the GP told the whistleblower they suspected coronavirus. The whistleblower says they asked, "It says Alzheimer's, is that right?" She claims the doctor replied, "Yes, I just put that because we didn't go out to see him. It was probably COVID, but we put Alzheimer's because he's over 80. The whistleblower told Channel 4 News care home deaths were up considerably on a broadly comparable time last year in their area, from 25% of all deaths to 41%, and there was suspicion around some of those not logged as COVID-19. Lower respiratory tract infection or pneumonia, those are classics, they said. Another bronchopneumonia, that means COVID to us, probably.
Properly recorded.
England's chief medical officer had this response this evening.
Obviously, everybody who sadly dies the doctor will make an assessment based on her or his view about what the cause of death is. That's what the death certificate says in all cases, and doctors take it very seriously and try to make sure that they get as much information to give accurate data.
A real, true, I would say old-fashioned man, family first.
This is Jim Barnes, 2 weeks before his death on Good Friday in Lincolnshire, aged 82. Because he tested positive, his death will make the official statistics, albeit because it happened in a care home, not anytime soon.
That feeling of loneliness, that must be the worst feeling in the world for anybody in this moment in time.
His son, Mike, did not get to say goodbye.
I think there's been too much focus on people in hospital, but I think there's been too little focus on the human tragedies. Every person who's died, there's 10, 20 people that's affected, and we're not hearing their stories, we're not hearing their pain, and it just becomes a number on a spreadsheet.
Jim was far more than a number on a spreadsheet, but his death has been counted. And the question tonight is how many have not?
Well, I'm joined now by Liz Kendall, the former Shadow Minister for Care and Older People. Liz Kendall, what should the public be told in terms of deaths every day?
We should be counting and publishing daily deaths from coronavirus outside hospital, including in care homes. They do it in Ireland, they do it in France. And in those countries, we've seen that coronavirus accounts, the deaths from coronavirus in care homes account for around half of all the deaths. You know, what's measured is what counts. And those deaths count. They should count in terms of our fight against the disease, but they also count for every single family member who's lost someone they love.
Do you think those numbers exist and we aren't being told, or they're not being counted yet?
Well, we do get statistics from the ONS, but the last ones we've had from them relate to the week ending the 27th of March. We're going to get another set of figures from the ONS tomorrow. That's not quick enough, and it's not regular enough. I mean, if you want to deal with the problem, you need to know how big it is, where it is, and how quickly it's spread. And where they do count it in places like Ireland, it's enabled them to go into areas where they've seen clusters of an outbreak, put the effective controls in place, do twice daily temperature testing of staff, making sure, absolutely sure they've got the PPE they need. So the reason you need those figures is not just for a statistic, it's to take action and solve the problem.
Now, so far, Keir Starmer, your new leader, has tried to be as constructive and as supportive of the government as possible. But over the coming weeks, thousands and thousands of people are going to die, partly as a result of government decisions. At what point do you then have to break ranks and start being more critical?
Well, what I want, and what Keir Starmer and the whole Labour Party want, is we want the government to succeed in tackling this virus, reducing the number of deaths and protecting as many lives as possible. That's why we've put forward this practical suggestion of counting and publishing daily the death rate figures outside hospital. We have also got to see the PPE and testing getting to not just care home staff, but carers who provide care in people's own homes. Look, families aren't allowed to visit anymore. So the only way that infection is going to spread is if it comes from a carer. And you heard how desperate those care workers are not to infect the people who they go to work to help. So the government needs to do more, but I think it's right that Labour is making practical, constructive suggestions, because what the country needs is results.
Liz Kendall, thank you very much for joining us. Well, our health and social care correspondent, Victoria McDonald, is here. We've seen some new reporting around the guidelines on who may or may not be admitted to intensive care.
Yes, so we're talking about deaths, but there is also before that the treatment and so on. But there are concerns about who is getting access to intensive care and therefore ventilators. The National Institute for Health and Care Excellence, or NICE, has put together some guidelines for critical care of adults with COVID-19, and it's a scoring system, and it's been developed using 3 metrics: age, frailty and underlying health conditions. You can see there, although it's probably a bit small on your screen. If patients have a combined score of more than 8 points across the 3 categories, this support tool advises that they should probably not be admitted into intensive care. Though, and this is very important, clinical discretion can override that decision. Now, there are a number of factors that have to be taken into account, as the ability of you to survive going into intensive care. Ventilation can be very brutal. It can cause a lot of damage to the lungs. There is some evidence to show that there is only a 50% chance of you surviving. It's about what you want as well for the end of your life. And again, there have been calls for people who are at the end of their life to make decisions in advance, in a way, about where they would like to die and how they would like to die, and that maybe intensive care isn't the right place for you.
Thanks, Victoria. Well, joining me now is Dr. Shazeb Ahmed, a junior doctor in intensive care at a South London hospital. First of all, what's the situation in your intensive care unit, and do you have the equipment and protective equipment you need?
Well, thanks for having me. Our intensive care unit has been overrun since the second week of March, with an overflow of ventilated patients into the recovery area. And this has stretched all of our resources, sometimes to sort of maximum limit. But we are coping, and we currently still have capacity. And currently we do have the resources and ventilators to keep admitting patients. Of course, it does take a physical and emotional toll on all of us, but currently, as it stands, we still have capacity.
Right, this question of capacity, though, is crucial when you look at this COVID decision support tool. Because what it suggests is that if you're in your 70s or 80s and have any of those normal underlying conditions that many people in that age group have, whether it's heart disease or hypertension or diabetes or whatever it might be, your chances of being admitted to intensive care to get that, you know, by definition, brilliant care is really quite low, isn't it?
Well, yes, it's low, but actually those decision making happens at a very senior level, and it doesn't only take into account the factors that you've mentioned, but actually the most important factors are the ones that put the patient at the center of the decision-making process, and those includes patients' comorbidities, their functional status, and of course utilization of resources has always been an important factor. But actually, you know, you still have a chance of being admitted into intensive care, given not only your age, but if your other comorbidities allow it. Now, an important factor to consider is actually, do you want to be admitted to intensive care? Because it is not an easy journey, and it takes a young, fit and well, healthy adult who has gone through intensive care up to 6 months to fully recover and be rehabilitated from that admission. And so I think there's an ethical side to it as well, not just a clinical side.
But do you see why that conversation, which keeps being had in public about, are you sure you want to go into intensive care, have a conversation about how you want to die, is putting older people and their families under a tremendous amount of pressure to basically say, OK, I'll give up and leave my bed for a younger person?
Well, actually, you know, this conversation is important, and there's always been a drive within hospitals, at least, to have that conversation early. We talk about ceilings of care and a CPR status often at admission for some patients, even before this pandemic. And so, yes, it's a very, very important consideration, and I agree with you.
So, I mean, if you are in your 70s, and you're a sort of a normal 70-year-old, you're not somebody who runs marathons, can you go onto a ventilator and can your life be saved if you get to the advanced stages of coronavirus symptoms?
Well, I think it's important. Yeah, sure. So I think it's important to distinguish between physiological age and biological age. You can have 70-year-olds who are very, very frail, and you can have 70-year-olds who have the health of, you know, a 40 or a 50-year-old. So I think this is what I mean about, you know, that decision-making at a senior level, because it's not just age as a standalone factor. It's actually the most important factors to consider someone for an admission into intensive care is not just age, but also their comorbidities, their functional status and their social status, social history and what they're able to do for themselves. You have 70-year-olds who can't climb a flight of stairs, and you have 70-year-olds who can run marathons. You know, there is a big difference between those two patients, and therefore just the fact that they're 70 is not enough to exclude you from intensive care.
I mean, the extent of patients that you've described must be incredibly distressing for you and your colleagues. I mean, how are you all? I mean, you know, how would you describe the mental health of your colleagues working under these sorts of situations?
Yeah, so I would say whilst the job has become physically more demanding, emotionally it's been much, much harder. We are seeing a lot of patients who are young, fit and well, and a lot of these patients, we can relate to them. We see our friends, relatives, colleagues in them, and we find it very difficult talking to the families who are finding it incredibly difficult to, you know, accept that their patient, their relative who was alert and awake and talking to them before they came into hospital is now not waking up. Some of us have made decisions like moving away from family members because we are worried about their health. And, you know, a lot of us have had moments of just random emotional release, like crying, because it does take a toll on all of us. But we are coping, and we will continue to do the best we can for our patients.